subject very close to my own heart. For those who don't know me, my name is Dr. Carmel Clancy. I'm one of the directors with ICU DDR, specifically in credentialing and accreditation. So lovely to be able to welcome you. So it's afternoon for me. I'm based in London, but for those of you who are joining us from all other parts of the world, good morning, good afternoon, and good evening. I have great pleasure in just giving you a very short background on our two wonderful speakers. To begin with, we have Dr. Dmitry Krupchalka, who is a medical officer at the Alcohol, Drugs and Addictive Behaviors Unit, Department of Mental Health, Brain Health and Substance Use of the World Health Organization. In this role, Dmitry is responsible for implementing a range of activities in prevention, treatment and care of disorders due to substance use, addictive behaviors and related health conditions. This includes contribution to the WHO normative guidance and technical support to countries, and dissemination of evidence through international research projects, workforce development, monitoring and evaluation, and enhancing joint efforts and advocacy in the area of alcohol, drugs, and addictive behaviors. Dmitry is a medical doctor and a psychiatrist by professional background with an MSc degree in global mental health, actually from the University of London, I noticed, Dmitry, from the UK, and doctorates in clinical psychiatry and global health from the University of Geneva and Switzerland. So welcome, Dmitry. Our second speaker working and presenting today with us is Dr. Brandon Gray. Dr. Brandon is a technical officer with the World Health Organization's Department of Mental Health and Substance Use, working in the areas of mental health and psychosocial support in humanitarian settings, disaster risk reduction, scalable psychological interventions, and mental health integration in primary and general health care, among other topics. Brandon completed his doctorate degree in clinical psychology at the University of South Dakota, specializing in mental health in humanitarian emergencies. So it is with great delight that I have to introduce our two colleagues who will be introducing, as you can hear, a wonderful topic. I'm sure that's why you've subscribed to the webinar series. So I'm going to hand over to both my colleagues to take it away. And as Verna said, I will be keeping an eye on the chat. So please do, as you're listening to the presenters, place any of your questions in there, and both myself and Werner will start to monitor that and make sure that we have them ready for a Q&A at the end of the presentation. So colleagues, over to you, and thank you so much.
Thank you very much, Carmel, for your very kind introduction, very detailed. And thank you to ICDDR colleagues for hosting this webinar, but beyond that, for all the support and helping WHO to reach your stakeholders, professionals all over the world. And also thank you for all your work you're doing to strengthening education and treatment and care for people with substance use disorders, but also beyond that to mental health. And thank you very much for your interest to the topic that we will present today with Brandon. So I hope my slides are visible now. And indeed, the topic we wanted to address is sustainable workforce development with a focus on substance use and addictive behaviors. And specifically, we wanted to give you an overview of the recently launched WHO guide for pre-service education, as well as update you on the current development on postgraduate education guide. Both of them trying to, again, improve the health workforce as a key component for health system strengthening. But before we go into the details for these guides and the documents, maybe I just give you a rationale and a challenge that we all have in front of us. So all people who work in this area, we more or less understand how big the challenge, but it's always good to look once again and also to highlight for other decision makers and stakeholders who are less familiar. So first of all, the global burden attributable to substance use and addictive behaviors is high, but I think it can be even said huge. So for alcohol, there are 400 million people with alcohol use disorders, either alcohol dependence or harmful use of alcohol. And it's linked to more than 2.5 million deaths happening every year attributable to alcohol. Then in the area of psychoactive drugs, there are 64 million people with drug use disorders. And actually in the recent World Drug Report, it's even a little bit more. And at least 500,000 deaths happens every year. But always when I present this figure, I think and I say that it's underestimation. I think the realities is that the burden is much higher because it's not only individuals affected, but also their families, the communities, and the broader society. Then just another line to keep in mind that we speak not only about alcohol and drugs, but also about addictive behaviors and disorders due to addictive behaviors, such as gaming and gambling. And while data are limited and not perfect, we can tentatively see that there are at least like around 20 million people with disorders due to addictive behaviors, be it gaming or gambling, which also shows the huge prevalence of these conditions, while treatment gap is enormous, even higher than for alcohol and drug use disorders. Then the second message is that there are few people who just have alcohol or drug dependence, because in reality, if you work with this population, you for sure notice that most of these people have comorbid mental health conditions and substance use disorders, or polysubstance use disorders, or substance use disorders on top of mental health conditions. So based on the different data sources, at least half, but up to 80% of people with substance use disorders also have comorbid mental health condition. And by the way, if there is a comorbid substance use disorders, then the risk of death, for example, is increased from 20 to 280%. It depends on the condition. So for example, if people with schizophrenia have comorbid alcohol dependence, then the risk is increased by 280%. And it's associated with additional years of life loss from 4 to 10 years. And finally, despite this burden being high, despite the high prevalence of comorbidity and impact, the treatment gap remains enormous. So the World Drug Report, again, just released the data a couple of weeks ago, and in the World Drug Report 2025, it's actually only 8% of people with drug use disorders who are in need of treatment, they do receive treatment. So more than 90% do not have access to treatment, and which is even more scandalous. There was a recent paper based on the analysis of data from the World Mental Health Survey, which looked into effectiveness coverage and actually showed that only 1.7% receive effective treatment. And in this paper, the effective treatment is very broadly defined. It's at least one evidence-based pharmacological plus one psychosocial interventions. And for alcohol use disorders, it's 1.4%. For drug use disorders, it's a little bit higher, but still, you see, like 98% of people don't receive effective treatment. And of course, we all need to work really hard to strengthen and to change this, strengthen treatment and care and to change this situation. And this requires a lot of different actions, from better governance to better financing, better access to medication, better collection of information, etc. But one of the cornerstone actions is to improve workforce, is to improve knowledge, skills, and amount of well-trained health professionals working in this area. Because again, we do collect some data on availability of workforce for treatment of substance use disorders. So here you see it's a little bit complicated slide, but let me guide you through. So for example, if you look into nurses, these are 3 boxes here. So we ask question to countries if they have nurses that work in the area of substance use disorders, and about 80% of countries answered yes, they do have them. But then the second question is if countries have continuous professional development and education and postgraduate trainings for this workforce, specifically for nurses. And these numbers went down. So it's like if 80% of countries reported having nurses, only about 60% have continuous professional development or education. and only about 1/3 have postgraduate training programs. But also the positive news is overall the health professionals do exist, like psychiatrists exist in 88% of the country, specifically trained to address substance use disorders, psychologists, nurses, social workers. But as I said, it's like if you zoom in, for example, into addiction medicine specialists, or sometimes called narcologists or addiction psychiatrists, it depends from country to country. But again, the same problem we see for all the health professionals. Even if they exist in country, much less of these countries have access to continuous professional education or postgraduate training. So there's a clear discrepancy between availability of professions and access to professional development and education. And just to show you on another graph that we collect also what level of educational attainment in the treatment of substance use disorders is possible to achieve in educational institutions. And about 10% of countries report that they do not have any access to like even short cycle tertiary education in this field. And also even if countries which are a bit more advanced, like a doctoral program or master program, they are not available in more than half of the reported countries. And the main educational attainment or educational approach would be short cycle tertiary education, when sometimes these are from international organizations and training programs that come to the country, deliver some training, and then they leave, and then when the funding stops, then this education program is ceased. So there's no really continuous development in that. And because of that, so in the a WHO global status report on alcohol and health and treatment of substance use disorders, there were key 8 messages, key recommendations on how to strengthen and advance progress with strengthening treatment and care for substance use disorders. And among these 8 messages, there are 2 related to health workforce. The second message actually about strengthening capacity of health and social care system, which is impossible without strengthening health workforce. And the number 3 is specifically looking at the need to accelerate training of health professionals at all levels. Then maybe it's also worth saying that like a WHO has different types of mandate in mental health, in substance use, but also there is a specific mandate to work on the health workforce, because there was a global strategy on human resources for health approved by our governing body in 2016. And this global strategy is providing a global vision and a framework for also setting goals, principles, objectives, and milestones for the health workforce agenda. And among other things, it highlights the need for education being competency-based. Competency-based means that it's not just, didactic curricula sharing knowledge, but it's a type of education which is an outcome-based, and that it puts knowledge and skills in the context of practice and in the context of health service provided. So it kind of adopts this knowledge, skills, and attitudes under the real world scenario of what people are supposed to do in their workplaces. And there are different competency-based frameworks that were launched by WHO. So here in this slide, you see just a couple of them. There was one on overall universal health coverage. It's like how to strengthen primary care workforce, on HIV, on eye care, on rehabilitation, and there are even more. So just some presented here. But what is really remarkable and why we are talking to you today, because that recently WHO also launched this competency-based framework for educating medical nurses and students in mental health, neurological, and substance use care. And this is what Brandon will give you now and address in more details. So is this maybe, Brandon, over to you?
Thank you so much, Dimitri. And I just want to first echo what you said at the beginning to say thank you very much to ICU DDR and Carmel and Verna for having us, and to all of the colleagues who joined to listen to the presentation today. So if you move to the next slide, Dimitri. Yes. So as Dimitri mentioned, we have recently started working more on addressing some of the challenges that we're facing globally in terms of workforce. And the approach we're taking is to, like other colleagues in WHO in this area of mental health and substance use, to look more at competency-based education and what we as WHO can do to support strengthening competency-based education in mental health care, in substance use care, um, through university-based education. So how we're doing this is, again, taking this competency-based approach. And I'll just describe what we mean by that before we go into the document itself. So the idea is really that competency to provide whatever care tasks one needs to provide in their work is developed through having the right attitudes, the right knowledge, and the right set of skills that all combine to make one competent to provide quality mental health and substance use care to people at all stages of their life. It's rather straightforward concept. I'm sure many of you, given your background, are already quite familiar with this, but this is the approach we're taking in some of the guidance documents we've developed recently and are continuing to develop. Next slide, Dimitri. Thank you. So for the portion of the session that I'll speak, I'll talk about our work to develop guidance on educating medical and nursing students in mental, neurological, and substance use care at first degree or undergraduate level. It's a term WHO calls pre-service education. I think it's a sometimes familiar term and other times not, depending on the country. But basically what it means is first degree or undergraduate level education. So why do we choose to focus on pre-service education? Well, the reason is that it's a way to start early by building confidence and competence in a topic as a foundational piece of education for future nurses and doctors. It reduces stigma, we found, and that's an evidence-based fact through different research studies by exposing students early in training to people with mental health, neurological, or substance use conditions. And so then it prepares graduates to, from the start, address physical and mental health together, rather than seeing mental health as someone else's responsibility. It's also a way to promote sustainability of skilled professionals, because it is somewhat more of a self-sustaining model in that universities do have their own systems of funding themselves, or in many ways at least have some sustainability, as opposed to one-off in-service trainings, which are often always externally funded. And so in a way, this approach can complement all of the in-service training and continuing education that we see happening through different international organizations or other perhaps less sustainable approaches. Next slide. Thank you. So then what we did is in 2021, we decided thinking about how we could address this gap in workforce and the gap in university-based education for medical and nursing students in mental, neurological, and substance use care. And what we did was we first started looking at what exists, right? What is out there? We did a large review of a number of different academic papers, gray literature, as well as several different curriculums from all 6 WHO regions to get a sense of what do medical and nursing schools teach now on mental health and substance use. What does that look like? What are the skills that they're developing, the attitudes, the knowledge, and how does that translate to practical application of the learners? And what we found is that actually it's very varied. It's quite different from country to country, and even within country among universities, there's often huge differences. In some cases, there's a nationally set curriculum, but the way it's applied can vary a lot. In other cases, there isn't. And so then what's within the university curriculum is quite different within country and across country. So we also then did a number of key informant interviews with topic experts, with current students, with past students, with large organizations, just to get a sense of, again, what's already existing, where are the gaps, and what should we as WHO be doing to strengthen this area of work. We held 2 consultations, and all of this developed into the idea that we needed to create some sort of guidance document based on best practices from around the world to understand what are the different competencies that medical and nursing students should have in providing mental health and substance use care. How can one go about developing those competencies? What are the tools? What are the assessment methods, the curricula, strategies, and the teaching methods to instill those different competencies, and then assess them over time. So that's what we did. We developed the guide you see here on the screen. You can access it there on the QR code, and I'll also put some links in the chat for the guide. And we finally launched it earlier this year in April after this long process of defining, drafting, revising. And many of you in ICU DDR gave us a lot of really good feedback from the beginning and throughout the process. So I again say thank you for that. I think many on the call were probably involved. If we go to the next slide. Thank you. So I'll go through a little bit about what's in the guide and how you might use it in your own work. So it's really divided into, I think you could say, 4 main blocks or 4 main chapters. The first is about preparing to change curricula. So it's about analyzing a situation, understanding the country context, what it is that medical and nursing students will ultimately be asked to do when they enter the workforce. And then, of course, it's about advocating with the right stakeholders who will be decision makers in the process, and planning for change over time. What's the scope of the curricula change or enhancement you will make, and what's the scale, and how will that, and who will be involved. And then there's a third chapter, chapter 3, about defining the competencies that you'll actually be implementing, and then how you actually go about enhancing a curricula through setting learning objectives, assessment, and training educators. And then again, a final chapter on implementation, about how to actually take what you've decided and put it into practice and do monitoring and evaluation. So if we look, you can go to the next slide. Thanks, Dimitri. Yes. So if you look more into the first block, I would say it's about establishing these clear goals and preparing and planning for curricular change as a critical first step. So in this chapter, the guide outlines key activities like establishing what we called a curriculum review committee. This is something we learned from many different educators around the world who'd gone through such a process. This is often a first step. Then they would conduct a situation analysis, work on advocating and securing endorsement from the school itself, but also sometimes at the national level with different ministries, and then developing, of course, a work plan and a budget. So all of these steps can put the process in a well-designed right direction. And the idea of this chapter is all about getting the right collaborators on board and taking this multidisciplinary approach involving various healthcare professionals. Next slide. So then the second block, this is actually in the third chapter after the introduction chapter. So chapter 2 is about the situation analysis and planning. Chapter 3 then gets into, I think, what's really the core, the meat of the guide. And these are the core competencies that we've defined for nurses and doctors to provide quality mental, neurological, and substance use care. So on the screen, you can see all 12 core competencies, and each competency is made up of a list or a set of attitudes, a set of knowledge that is needed, and a set of skills that are required to be competent to have that competency in providing quality mental, neurological, and substance use care. So it was quite an iterative process to come up with these 12, but these are the ones that we came through a large set of consultation, through review of the literature, and looking at different curricula, defining this core set of 12 competencies that we felt were applicable across settings, really in any country, for setting a basis for what medical and nursing students should know on providing quality mental, neurological, and substance use care. Next slide. Great. So if we take an example here, this is the example of clinical emergency care. I think it was number 4 on the previous slide, but they're listed in no particular order. Again, you can see here, this is the competency broken down into the required attitudes, which are things like foundational attitudes, like being genuine and compassionate, as well as specific attitudes that are really necessary, like being solution focused and able to remain calm and composed in a crisis situation. Then there's, of course, the column about what students will need to know, things like emergency protocols and best practices, such as related to suicidal behavior or withdrawal from substances. And also covering both non-pharmacological and pharmacological interventions, as well as things like national standards, legislations, and regulations for responding to a clinical emergency. And then there's the third column, which is the specific skills that are required for this competency, things like assessing and managing emergency presentations that are common in different types of conditions. And again, covering how to actually apply non-pharmacological and pharmacological interventions at the level of the healthcare worker. Next slide. So that's the chapter 3. If we go to chapter 4, then it's about how to take the competencies and actually put them within a curriculum, how to enhance an existing curriculum or to develop a new one if one on this topic isn't really existing, or if one's starting to develop a new curriculum. How can you integrate some of these competencies within that work? And so the guide gives examples of how to take that situation analysis in chapter 2 and then inform the competencies from chapter 3 in defining learning objectives on how you actually go about developing those competencies. So key activities that are covered in this chapter include things like planning the learning experiences and how you shift attitudes, how you build knowledge, and how you develop and apply skills. So for example, the guide covers methods to shift attitudes, describing some of the most effective ways of changing stigmatizing perceptions by involving people with lived experience as co-educators. This is an example of a method we really emphasize because it has a lot of evidence behind it, as you may know. There are also many active learning strategies such as case-based and problem-based learning we described. And there are also participatory methods such as flipped classrooms where students lead research presentations and seminars. Many different examples of how to go about skill development as a central focus for competency-based curriculum as well, through role plays, through simulations, through real-world clinical placements. So all of these things are covered quite in depth in the 4th chapter, and emphasized in how to go about actually building or enhancing a curricula based on these competencies. Next slide. Great. Yes, so then within this 4th chapter, there's also a number of examples giving specifically outlined ideas for how to go about this curriculum enhancement. So examples where you would take a specific competency and then you would lay out specific learning objectives, experiences, and assessment methods that are applicable to that competency. I think we can look at one on the next slide. Yes, so here, if we take the example of managing alcohol use disorders and substance use disorders, right? That was one of the competencies among the 12. And we look at the specific learning objectives that you could choose or you could apply to this competency. There are examples for the learning objectives you might set in terms of attitudes. Could you go back one, Dimitri? I think there's a timer on this slide, maybe. Perfect, yeah. There's examples for the specific learning objectives for attitudes, right? Like about adapting an approach that is non-blaming, non-judgmental, non-stigmatizing, but also then about knowledge and skills that are necessary for this competency in managing alcohol use and substance use disorders. Next. And then the same is true for the learning experiences you might want to use to shape the right attitudes, to build the right knowledge, and to develop the right skills. For example, information sharing lectures, but also myth-busting simulations. There's examples of what these are and how you go about them. And knowledge, self-directed learning, but also group discussion, student-led research, lectures, seminars, many of the classic examples mixed with some more innovative things in skill building like role plays, simulation and case studies, shadowing and clinical practice, right? So many different examples that are described here are then built on or expanded within chapter 4 of the guide. If you go to next. And then there are also a number of different assessment methods you might use to assess how well one's reaching those learning objectives in attitudes, knowledge, and skills for that competency of managing alcohol use and substance use disorders. So chapter 4 is really all about how to take it and apply it, and giving many different examples in doing that related to some of the core competencies. Next. Perfect. And then chapter 5 is really about implementation and solving problems or overcoming barriers in the implementation practice. So the guide, I think what we tried to do is to recognize that many institutions will face different resource constraints, particularly when it comes to this topic. And so we tried to offer different practical tips for overcoming some of the common challenges we heard from different stakeholders in the process of developing the guide. Things like rethinking traditional teaching methods, replacing lectures with more participatory approaches, making even very small changes to an existing course to build some of these core competencies, where one isn't able to really revise an entire curriculum, but can start small and build on what already is there to enhance some of the ways that knowledge, skills, and attitudes are being developed. To also harnessing community resources. And throughout, we give a lot of case studies on how these different approaches are used, or how they have been used in different countries to overcome some of the barriers that are very common with this topic. Next slide. So this is our pre-service guide, and I really want to take the chance to encourage us to act together to address this gap in workforce treatment, workforce and treatment for people living with substance use disorders, to actually take this forward, to download this guide, to share with educators and decision makers, and help transform how medical and nursing education is really shaped. Because I think together we can really make a difference for millions of people by improving care through this effort. So download the guide. I put in the chat a number of other resources related to it, and I hope it's useful for you. And if you have any questions throughout the process, I'll also put my information about how you can contact me, and we can discuss further this resource if it's of interest to you. So I'll stop there and I'll hand back to you, Dimitri. Thank you.
Thank you very much, Brendan. I think it's just to add, it's also a unique WHO resource which brings together several areas like mental health and substance use and neurological conditions. It's so if it's implemented, then it's also an opportunity to increase the holistic care and see a person as not just being like with alcohol dependence or psychosis, but it's also opportunity to implement this holistic approach. So, it's great this document is out, and indeed it can influence the area. But one of the gaps also is that education doesn't stop at the pre-service level. So when people finish their undergraduate, when they start their career as a health professional, there is never end for your knowledge improvement. Especially if you specialize in one area or the other, then of course you need to have much more in-depth knowledge, skills, and understand the sensitivities with attitude. And to address that, I wanted also to update on the work which is not yet done. So what Brendan presented, it's already out, beautiful document. And here we are still working on the WHO guide for postgraduate now education, specifically focusing on substance use and addictive behaviors. And what we have done so far, we also mapped all the competency frameworks that we could identify. So we identified 10 competency frameworks, which are large, but then also a couple of smaller competency frameworks or isolated to some of the topics. So we also try to map and collate and to see what are the commonalities and differences. Then we did an intense expert consultations on how to structure the framework for postgraduate education. We have conducted a global expert group meeting in last year in Changsha, in China. So basically, hearing additional feedback and thinking together with experts from 15 countries, again, how to move forward. And then based on all this work, the principles, the structure, and the competency framework is more or less defined into the first draft of the practical guide. And now we need to, of course, still go into the in-depth additional consultation with this draft and put it in the context which will help implement it, like what Brandon said. So currently the focus was on the competencies themselves, but how to implement it for postgraduate education, it's still to be addressed. We will be doing another expert consultations next year, but meanwhile, we'll be doing some peer review. So it's planned for next year or maybe in 2 years. A lot also depends on the situation. But maybe just to show you what will be there. So we go into more details on the competencies, and here you see what are the key domains. So in addition to just practice, which like a domain of practice would cover any competencies related to interaction between specialist and the person with substance use disorder and family members. That would include how to provide evidence-based care, trauma-informed care, how to be effective in communication with patients, families, carers, also clinical decision-making, etc. But then we go into more details of the professionalism under the domain 2. It's on how to manage risks, incidents, errors, how to improve quality of care, how to ensure patient safety. Also, here we go into ethical principles and professional standards, professional boundaries, and all other that would define professional as a profession. Then the domain 3 looks into the learning and development, because we also thought that it's absolutely essential that people have competencies and know how to improve. And not only how to improve themselves, but also how to help other colleagues and how to teach even, and how to share knowledge with other colleagues and with also other professionals who might be not specialized, for example, working in the team, and then how to ensure that your team is learning and how you ensure that knowledge are shared. And then also it goes into details on management and leadership, how to manage the team, how to manage the service, as well as how to manage research, by the way, programs and research data collection, data coordination, etc. And finally, but not less important, we also think that professionals in this area need to know how to play a role in prevention, how to play a role in community actions, and how also advocate for actions in specific settings or country. And then this framework, these are like a main 5 domains. But then there was really highlighted during our consultation, because we should not just stop at the specialized workforce, because there are also other workforce which are not specifically specialized in substance use and addictive behaviors, but they also need to have postgraduate education, such as family medicine professionals, pediatrician, gastroenterology, infectious disease doctors, emergency medicine doctors, because they all often or rare, but they meet and they encounter people with substance use and addictive behaviors, and they also need to know how to address it. But of course, the question is how much in depth and how to separate. So of course, we want that addiction psychiatrists are the most, addiction medicine professionals are the most competent, and they have all the competencies to implement the activities. But at the same time, it's not an easy decision on what type of and how much in depth other professionals should go, because also it depends on settings and countries. In some countries, there's a easy referral to addiction psychiatrists or addiction professionals, but in some countries where they're not available, then this less specialized workforce need to play a higher role. So just to give you like, it's like an example, so it's like if we say that addiction psychiatrists should have all the competencies, they should have all the knowledge, all the skills, but then maybe addiction medicine should have some essential competencies and then some like a more advanced. And then maybe a general psychiatrist, the requirements would be a bit reduced, and similar, a little bit less for general practitioners, obstetricians, gynecologists, emergency medicines. But it's a hard decision now to define which are the core and which are additional competencies, because the variability of settings is so enormous. So we were thinking maybe even not to structure it by professions, but by profile, or like what are the work requirements for this specific professional, which is positioned in one or another settings. So just as a little bit of reflection on current thinking, it's not yet decided finally, but just to see that we go beyond just narcologists or addiction medicine or addiction psychiatrists. And please look for these guys an update from us. It's hard to say when it will be out, but we are working on that, and hopefully in the next couple of years. So now maybe just to conclude both presentations from me and Brandon, as we presented, and as probably most of you know, a huge burden is attributable to substance use and substance use disorders, and a huge comorbidity, scarce access to treatment, enormous treatment gap, while there are effective solutions, effective interventions, which just need to be delivered. And then the health workforce plays absolutely essential role. But there is a need to a more comprehensive, sustainable, and continuous system-level actions on prevention, on harm reduction, on treatment that would be in line with essential quality standards, such as international standards for treatment of drug use disorders or others, or WHO guidelines. But without workforce, it's impossible to implement all the standards or improve quality. So limited workforce, and especially limited access to education, is a major barrier for implementation of these effective actions and solutions. And competency-based frameworks could be a solution, how to bring this knowledge to people in need and ensure that the workforce is not just once trained and forgotten, but that the workforce has access to continuous development for all levels of professionals, those specialized and non-specialized, those who have not started providing services, and those who are already in service provision. And finally, I think it's probably a message that we would like to call for actions, because we want to thank you for actions and also say that it's our joint commitment to identify and utilize existing opportunities. So all those people who are in this webinar or who will be listening to the recording, please think, what are the opportunities? Use the guide that Brandon presented today. And I think many things can be changed with just talented and dedicated people in places like Carmel Clancy, who is moderating this session. And with this, Carmel, over to you. These are QR codes for the guide presented by Brandon and to the most recent report on the postgraduate guide development.
Fantastic.
Thank you.
Fantastic. Colleagues, seriously, you know, what a tour de force, as they say, in terms of the work and the presentation. I can see from the chat, and Brendan, you've already very kindly started to respond to individuals. There is great interest, which is of no surprise. And I would just, you know, on behalf of colleagues who are here and colleagues who will be listening to this webinar over the next few weeks, thank you so much for the work that you have done and for your commitment to this space. It is, you know, it is quite concerning to still see the statistics that you are presenting, Dimitri, at the very beginning of this webinar. It's actually, you know, it belies belief, really, that given how we know substance use impacts at a public health level and at all levels of society, it is completely indiscriminate. It doesn't really matter where you're living or indeed the quality of your life, how substance use impacts. And to the fact that we are still stating that 98% of people are not receiving effective treatment is somewhat horrifying, really. And it, you know, at times you feel like you're in an echo chamber. The people who come to this webinar, are all working in this space. People like yourselves with your dedication working in this space. The question really is, how do we get this message to the ordinary people, who are working within our health and social care workforce, to understand how we need them? And it is all our business, not just the specialists. So this work that you've done at the pre-service education, to me, is a game changer. I have always been very clear that, having come also as a dean of a university, that we tend to, as the saying goes, I don't know if this translates in other languages, but when the horse is bolted, already. Whereas what you are very kindly and nicely now navigating us towards is to still do it while the horse is in the stable and not when it's bolted. So catching our next generation of health and care workforce is so imperative, to explaining to them and to showing them that they need to understand and have these competencies, whether they go on to be a specialist in the addictions or the neurological field. It doesn't really matter. They need this as a common core set of skills and attitudes and knowledge for their practice going forward. So thank you again. You will see lots and lots of questions have come up. The first one, which again, thank you, Brendan, you've already helped us enormously by answering some very specific questions. But the one that's coming up, which we actually touched on, is training. I have to say, the guide itself is a very nice guide. When people, if you haven't familiarized yourself and you will start to look at it, it is a very easy guide to follow. It's a very clear signposting, step 1 to step 2 to step 3. So in some respects, I would say that really without a huge amount of training, you should feel very comfortable picking up the guide, taking it into your institution and talking with your colleagues to see what it is you can do without really any formal training. But I do appreciate there may be a wanting for people to come together like a community of practice, to share good practice in the implementation. So I wonder if you could speak to that, perhaps Brendan or Dimitri, about how we might assist the wider community to build that community of practice of people who will start to implement this. Is there a way, either through with ICU-DDR or ISUP, organizations that already have a very nice gathering of professionals, whether this is something we could be supporting the community with?
Yeah, I think I can go, Dimitri, and then if you want to add,
You go.
too. Yeah, Carmel, I think it's a great question. It's something we've definitely been exploring on how we would do it, and I think ICU DDR is a place that makes obvious sense because people are already coming together to work on shared areas of interest, right? So if this is something that becomes a shared area of interest, then it makes sense. And for us, I think it'd be really useful. But also we hear this question a lot because I think it's a sensible one, is how can we learn from each other, and who's already doing this, or people who are starting to want to use it at the same stage, to be connected in some way. So I think, I don't know, I don't have a specific answer on what it would look like yet, but I think it'd be great if we could explore it and find a way to make some sort of exactly community of practice, because again, I think it'd be useful. So it's definitely on our mind. We don't have something yet that exists, but I'm seeing it now even more from this conversation that we need to work on it. We need to make it happen. So I think it's next on the agenda for this area of work for us. Yeah.
And I wonder, colleagues, as well, and just for the discussion as people are listening to us, there would be a natural, I think, research question that would then follow, I suspect. So for those who are researchers, particularly with the research orientated mind, might think, well, this could be something also as we develop the community of practice in the implementation and rollout, looking at the impact, sort of in terms of pre-knowledge attitudes and skills, and then post-knowledge attitudes and skills, and even longitudinally looking to see whether those professionals, as they move into in-service, sort of work, what and how they take that knowledge to to their practice going forward. So I think just I'm sparking that just as a thought. As you say, we don't have all the answers yet, but it's something to think about, that, you know, we could build, or there could be something that could build around that from a workforce research question, looking at the implementation of this guide. So so thank you for that. There's some other, as people are thinking and perhaps reflecting on the presentation, I put in some prompts just for other questions that might be useful around that. And one is, I was just wondering, because with any of these wonderful guides, we need the politicians, don't we? We need the policymakers. And I wonder if you could speak to that, about how can national policies better support the integration of this sort of training. You know, what else could we be doing as a call to action as individual advocates in our respective roles or organizations, or indeed at country level, to put this in front of those who have the power, so to speak, to demand, in actual fact, that this starts to make its way into curricula at university level. So I wonder if you'd like to maybe speak to that.
Maybe I can take it also quickly. So I think that first of all, it's a wonderful question and absolutely essential. And in addition to the guides being just a guidance, I think it's also an advocacy tool. Because if you think of the politician and decision makers, you know, they sometimes responsible for all the variety of health conditions. And it's sometimes first a matter of prioritization and see if there is a need. But also sometimes people can be a bit blocked due to a complexity of the topic. And having a concrete guide which says you exactly what you do step by step is kind of opening not their eyes to see the area, but also it's paved their way to see the road. And so I would maybe say obvious thing for all the participants, that look for existing opportunities, but also try to build an opportunities based on the, you know, the civil society power, or, you know, your contacts, and in general, if there are any policy and decision makers in this call, I hope that it also shows you the why to do as well as what. So I hope this has helped.
No, I like that, Dimitri, because often you're absolutely right. Because the problem is so large and those statistics you've shared are so overwhelming, you can almost be paralyzed. What can we do? So here we have a very beautiful guide saying this is actually how you can start. So I think, you know, for those who are listening, who are in the position of being, you know, sort of important advocates, yes, this is the problem, but we do actually have some tools to navigate, to assist us. So if you can just support us a little on implementing some of these tools, that is a beginning. So I think that's a positive message. Often we get, you know, quite depressed that, you know, sometimes it feels too much. But I think that's the beauty of today's webinar. Here we're talking about a tool that can really affect change, and it's free. You know, that's big at the moment, as we know, given the challenges many countries are facing around funding. But to have a resource that is coming out of the World Health Organization showing and signposting and navigating is wonderful. So really, there's almost no excuse, I would like to argue, but we know it's a challenge. I wonder also, because you talked about the process and you had a huge stakeholder engagement, which was amazing. Whether, you know, what do you think the role also for active agents of change, and I would put the regulatory bodies or professional bodies. I wonder, is there any feedback you can share with us about if you've had a response from those particular organizations and how they could affect or support the rollout as well?
Yeah, I can maybe speak to that.
Yeah, go ahead.
Yes, so this is I think, very essential piece of the puzzle. For us, we were engaged throughout the process with the International Association of Medical Regulatory Authorities. I always get the name wrong. But they're a large organization, a big body of exactly this, these national regulatory bodies in healthcare. And so I think from that process, we learned that it's very essential. It depends on the country exactly what the state of the regulatory authority is, but I think that's very essential because if you boil it all down to what a student learns in medical or nursing school and what they actually care about, it's ultimately what they're tested on and what they need to know to graduate, right? So if it's not part of what's needed to graduate, people just don't have the time, right? They're just too busy in medical school.
Exactly.
Overwhelmed, right? So, and a regulatory body has such an influence on setting those standards on accreditation and what gets into that actual testing process, or what's actually assessed. So I think the regulatory body is really at the core and very essential to set those standards nationally and make sure mental health, substance use is part of that, so that then medical and nursing students will see from the beginning, this is part of my responsibility because it's something I need to know to graduate. And I think that makes a huge change. Yeah.
Yeah.
And maybe just
And
add.
Dr. just for
Yeah.
Brandon, there, your mic dropped down slightly,
Sorry.
Brandon. So if you could turn that back again, that would be great. But Dimitri, please come in.
Yeah, one of the challenges that was very visible during situation analysis is that the topic of substance use disorder specifically, if it's even included in the curricula, it's not included in the examination, in accreditation. And then, of course, it also demonstrates how much priority students would give to it. So it's absolutely essential. But also, I think this guide makes the work for regulators easier because, as Brandon presented, it gives the ideas how assessment can be done.
I love that. And you're absolutely really essential. If you do not put it, sadly, still, if you don't put it in a test, people think it's not that important. So I think there is that whole loop end to end, not only in the curriculum, but also testing. So thank you for those really important points. We literally have about 2 minutes, and a great question has come in from Jonathan. Jonathan, thank you so much. How is the implementation utilization of the guide going to be monitored by presumably your office? So I wonder if you could speak to that.
It's a great question. It's a challenging question always with every WHO resource because everything we produce is open access and you don't really need to tell us if you're using it. So the good side of that is that everything's free, it's easy to use, it's easy to get, you don't have to go through a person to get to it. The downside for us is that we actually don't know when people are using it many times. So for us, it's really helpful if you are starting to use this guide, if you just let us know, because we'd love to learn from you in that process and connect you with our country office in the country where you're working, because that's one way we can monitor implementation and support is through our country offices locally or through our regional offices. So I would just say, if you're using it, let us know. Those are the cases where we can really follow up, support, learn from the process, and then share what knowledge we gain there with other countries or other implementers. So really, if you do use it, I shared my email, or I'll put it again. Just let us know so we can learn from you as well.
Wonderful, wonderful. Well, thank you so much. We are just coming beautifully to the top of the hour, and for your opportunity to share and to let people know about this wonderful guide and tool. Thank you so much for a wonderful presentation. As always, it's a pleasure to be in your company, and thank you everybody who joined and made the time to listen in. If you have colleagues who couldn't make it, please let them know they can access this. I know that Werner sends out a follow-up. The presentation will be followed up to everybody who registered, which was, we believe, in excess of 100 people. But please do pass this on. This is free information. We want it to be disseminated, and do watch this space. Please, ICU DDR will be continuing to support our colleagues in the WHO, and just watch this space. Hopefully we could maybe take some of those actions that we've discussed to look at implementation and rollout. But thank you so much, everybody, for your time today. It's been an absolute pleasure, and all the best for this wonderful, wonderful guide. Thank you so much, everybody.
Thank you. Thank you very much.
Thank you. Thank you. Take care.
Bye
Thank you,
bye.
Verna.
Have a great
Thank
day.
you so much. Thank you, everybody. Have a good rest of your day. Thank you, Verna. Thank you.
Bye.
Bye-bye.